Uh, Thank you, everyone. And I'll be speaking about the results of the novel CMT flex lens in comparison with the standard scleral fixated lens and the iris claw lens. So I have no financial disclosures, whereas my good friend Dr. Nivian is the innovator and the patent holder for this lens. So a little background about the subject. We know that when there is a posterior capsular compromise, surgeons fall back on two standard options, that is the scleral fixated IOL or the iris claw lens. Now each of them have their own advantages and disadvantages. The advantage of an SF-IOL is that it's in a more anatomically correct position. You don't disturb an important tissue like the iris. But the disadvantage is that the surgery is relatively long, it's time consuming, it requires a learning curve. On the other hand, an iris claw lens is a relatively simple surgery, but on the flip side, you're anchoring the lens to an important tissue like the iris. So there is a chance for pupillary distortion or a little anterior segment inflammation. So this is where the CMT flex lens was developed. We tried to mix and match. We tried to retain the advantages of both while eliminating the disadvantages. Retaining the advantages, by which I mean, the surgery is kept as a simple surgery, whereas anchoring to the iris is eliminated. The anchoring remains to the sclera, so your pupil distortion is eliminated or intraocular inflammation is eliminated. Now we've presented the design of this lens, the dimensions of the T, the vault of the optic, the case reports. We presented it in standard international journals. There have been a lot of acceptance. We've received a lot of acclaim in conferences where the videos were played. We've had people coming up to us and telling, no, we'll be very happy to try the lens. But the question always asked was, how does it compare with the standard options? How does it compare head on head with SF-IOLs and iris claw lenses? So that was precisely the aim of this particular study. We wanted to find the visual and refractive outcomes of the CMT flex lens and compare it with the standards. And more importantly, we also wanted to see whether the undesirable effects are also comparable. So how was the study done? It was done in two tertiary eye care hospitals in Tamil Nadu. It was prospective, non-randomized, for the simple reason that it's difficult to randomize surgical aphakia. We had strict inclusion criteria. We took up only patients with surgical aphakia. For a period of 3 months, we had 112 eyes. We lost about 39 of them to follow-up. So we had 73 eyes in all, and they fell into 3 groups like this. So these are all published techniques. So for the sake of brevity, I'm not going to go into the details of the technique or how it's exteriorized. But suffice to say that this is a hydrophilic single piece lens which has a T-shaped haptic, and handshake technique is used to exteriorize the haptic and anchor it to the sclera. So moving on to the results, what were the numbers that we found? I'm not going to go into complex decimals or statistical analysis, but I'll show you what the data actually means. Now these are the 3 groups. We found that there is no difference in the 3 groups on the basis of age, gender, axial length, or IOL power. But we did see that the time between the first and second surgery was significantly lesser in the iris claw group, and of course the iris claw patients had fewer patients with lenticular remnants that required a pars plana vitrectomy. Now coming to duration of surgery, of course iris claw lens surgery was significantly shorter in duration, and one patient with an SF-IOL required resurgery. When it comes to refractive error, we saw that iris claw lenses had a significantly higher hypermetropic shift, and in visual acuity, all 3 lenses were similar. And that is seen in these box whisker plots showing hyperopic shift in the ICL and best corrected visual acuity wise at 1 month and at 6 months. All the 3 groups were similar. Now I come to the more important part of the undesirable effects. We saw that corneal edema or IOL dislocation or vitreous haze were similar in all the 3 groups. Whereas when I talk about AC reaction, irregular pupil, or IOL tilt, of course the iris claw lenses were noted to be significantly higher. And there was haptic exposure in a couple of patients with the standard scleral fixated lens. So to discuss this, a few of the points thrown up by our study were already well known. We know that iris claw lenses surgery takes lesser time. The visual results are similar. Iris claw lenses probably distort the pupil more, have a little bit of inflammation. But what our study adds is that the CMT flex lens is comparable to both of these lenses based on the visual outcome and better than the iris claw lens as far as the refractive outcome is concerned. And importantly, I keep stressing on this, importantly, the complication profile is also very, very similar to the standard options. Of course, we had a few limitations of our study. The sample size was small. It couldn't be randomized simply because surgical aphakia, some surgeons preferred to complete the procedure then and there, and we had a shorter period of follow-up. Nevertheless, we were able to derive certain valuable conclusions from our study. We were able to show that the CM T-Flex lens, in comparison with the SF-IOL and iris claw lens, it has similar visual outcomes and better refractive outcomes than the iris claw lens. When both the scleral fixator, that is the standard scleral fixator, and the CMT flex lenses are compared head on head, we see that CMT flex lens has lesser haptic exposure. And when I talk about complication profiles like inflammation and pupil distortion, we see that CMT flex is very, very comparable to the standard SFIOL and really better than the iris claw lens. Thank you for the opportunity and time.
Do you think an attempt to measure the endothelial cell count would have been an additional help?
It could.
Because I didn't see that.
We did not, sir. That could be added, definitely.
So also, was there any attempt made to measure the white to white?
Yes, sir. Every patient has a white to white measure in the IOL master. And this lens comes in a standard size.
Yes.
It's of 13 to 13.5 millimeter, if I'm right. I just forgot the dimensions. But you see that U-shaped haptic, the base of the haptic, sir. That allows for, bigger white to white dimensions as well.
So meaning to say, only if you know that, you can precise the position on both the sides.
Not really.
In the sense, one stem may be longer and the other side a shorter stem. So how do you,
stem of the IOL?
No, the haptic. The exterior is haptic.
They are of similar size, sir, on both sides.
No. There may be more exposure on one side as compared to the other side. If you're not really equating from white to white and the port. And
I see. Oh, you're talking about the exteriorization point.
Yes,
we
yes,
exteriorize it 1.5 mm behind the limbus, sir, on both sides, equally.
I think what he meant was, if it's a large eye, and you said that the fenestration in the haptic is adjusting or accommodating for the pull.
Yes.
What he means is it pulls the lens and maybe just elongates a little bit, so it might just have repercussions as far as the shape of the lens is concerned. I was a little taken aback when you said the iris claw IOLs did have a hypermetropic residual refractive error. What I have seen in my practice is it's the converse of that. They actually have a myopic residual error more. The reason for that is the power adjustment when it's done, done wrongly because their A constant is very low, and also that it sits more anteriorly, even in front of the sulcus, where the sulcus would be. So further subtraction has to be done on the IOL power, which normally surgeons in the heat of the moment don't do.
In fact, this study helped us refine our iris claw practice as well.
And I'm also not surprised to see that you did find nuclear remnants in iris claw IOL patients, because mostly they're done by anterior segment poor surgeons like us. So once you have a complication, you just panic and the pupil comes down on you. One of the red flags when it comes to posterior fixation of iris claw is, I just wanted to know the figure. How many of your aphakics were post-vitrectomized eyes?
None of them were vitrectomized at the point of inclusion, sir. Actually, how this works is that if the primary surgeon feels that he can place an iris claw then and there, if he's got no nuclear remnant, he goes ahead and places it. If not, every case comes to the vitreoretinal surgeon. So we will do a complete vitrectomy, remove the nuclear remnants if any, and then place the IOL. So to answer your question directly, were the eyes vitrectomized before the second surgery or before the IOL was placed? No.
None of them? None of them.
I mean, not before they came onto the table. So vitrectomy was done on table.
Yeah, and then that's what I'm saying. I mean, fine. I mean, now you tend to evaluate the patients when their eyes have been vitrectomized, right?
Yes.
So the reason why I'm asking this is the flutter of the iris in post-vitrectomized eyes actually causes a lot of issues with the posterior fixation of the iris claw IOL. So I always send out a red flag to my fellow surgeons not to use an iris claw IOL if the patient is secondarily being done after vitrectomy, because the iris flutter also tends to flutter the IOL.
Absolutely.
And sometimes the patients complain of a very strange oscillopsia. They say that they see the vision is clear, but it's kind of shaky. So since I see that the plate that you have at the end of the haptics obviously is exteriorized, and then it opens up and occupies its position. That's what I understand from the design at the first look.
That's right.
On the sclera. If the eyes are vitrectomized, the iris flutters. Along with that, it must be having, the iris has to have some kind of bang effect on the IOL. Does it, in your experience, I don't know what's the follow-up schedule that you have in your study, has it really affected the location of the IOL? Does it push it back or?
Not at all, not at all. This looks like it's a hinged IOL and a 2-point fixation. It actually is a 4-point fixation, because once the haptics come out, they anchor themselves really well to the sclera. You're coming out through a 25 gauge incision, which is sub 1 mm, and the width of the haptic is also sub 1 mm, but the T shape really anchors it well to the sclera and gives you a 4-point fixation.
What's the width of that T?
I really forgot, sir. At this point of time, I'm not able to remember, but it is sub 1 mm. It is a little larger than the 23 bore, the bore of the 23 needle. So it sits in perfectly.
Yeah, it sits perfectly at the outset, but what I meant was, if there is a mechanical movement, since it's a hydrophilic design, you said,
yes,
it's a very soft material.
Right.
So it just might slip back, or, because the plate is there, and I can completely understand that it's flared and it anchors it well. But there could be a bit of sagging inside the wound, since it's hydrophilic, and the material of hydrophilic lenses, generally speaking, are very soft. So maybe a long-term study could be done.
Definitely, so definitely. It's
but very interesting design, I must say. And yeah, rest of the things were fine.
Yeah, I was to also ask the same point. It is more malleable and soft.
Right.
Unlike those rigid ones which you are going to extrudize in the Gabor-Sharett tunnel. They are strongly fixed. But there is a possibility that there may be some, in the long run, some laxity or something.
So far, we've not had any. It's like, there's our regular single piece hydrophilic lenses in the bag.
But mind you, they are sitting in the bag,
Yes,
snugly
yes.
fitted. But
Right.
here only the 2-point
huge
fixation
bit
and
of
a soft material.
Right.
There's a chance that there could be some sort of
So
flexibility
we've not seen
there.
any so far.
No, some sort of a
As
flexibility.
sir said, we'll have
Yes.
to
Yeah,
look at
you
it
may
for
have to
a
look
long
at-
period of 5 years.
Watch
or
out
so.
for it in the
Yeah.
future, yes.
Thank you.